FNP 597, SOAP note for pneumonia. Introduction, Donald Additional Walker is my name. My clinical site type and location, Administer Medical Associate, family practice located at 3330 West 177th Street, Suite 3G, Crest, Illinois. Brief description of the case, IDCC, a brief HPI. ID, name, patient's name modified as Jane Doe. Patient is 65-year-old African-American female with a medical history of mild COPD, hypertension, hyperlipidemia. Arrived at the clinic in the company of her daughter and complained of shortness of breath that began a week ago. Patient is allowed rented × 3 and she's a reliable historian. Chief complaint, I'm here for shortness of breath that has been ongoing for a week. HPI, brief HPI, a 65-year-old African-American woman with a minor history of COPD visited the clinic with her daughter. She reported shortness of breath, weariness, fever, and productive cough. She used a Brodor inhaler twice daily, but found it only slightly helpful. She had bronchitis over a year ago and was treated with antibiotics. She admitted to chest constriction and she quit smoking cigarettes about 5 years ago. Describe why the case was meaningful, memorable, interesting, or challenging to you. Meaningful, as a healthcare provider, I have a patient in the real world who is dealing with a medical problem that requires an urgent medical intervention that I must provide by making a quick decision. It's memorable because it's unique, and because of the physical exam, various questions that I was asked of the patient, the assessment that was carried out, the diagnostic tests that were considered, the different diagnoses that were suggested before reaching a conclusion of determining the right diagnosis for this patient. Challenging in the sense that I remember the patient didn't want to go to the hospital, but I had to explain to her to trust my judgment or my decision, that I have her best interest at hand. And everything I'm going to be doing is going to be individually tailored for her care. Presentation of case. Subjective information, ID, name modified to Jane Doe, 65-year-old African-American with a history of mild COPD, arrived in the clinic in the company of her daughter and complained of shortness of breath that began a week ago. Patient is allowed written × 3 and she's a reliable historian. She complained, the chief complains, I'm here for shortness of breath that has been ongoing for a week. HPI history, a 65-year-old African-American woman with a minor history of COPD visited the clinic with her daughter and complained of shortness of breath that started a week ago. She further asserted that the signs of breathing difficulty were followed quickly by signs of weariness, fever, and positive productive cough with yellowish greenish phlegm. She reported having weariness, fever of 101 at home today, and was confirmed to 101.9 when she got to the clinic. However, she made the decision to visit the clinic when she noticed a severe shortness of breath with an even slight exertion while strolling about the house. She claimed that she has used or has been using a Brodor inhaler 2 to 3 times each day. It was only slightly helpful. She stated over a year she had bronchitis and was treated with antibiotics for it. Although patient denied having any chest pain, but she admit occasionally feeling constricted in the chest, which may have been brought up because of frequent coughing episode. She used to smoke a pack of cigarettes a day for 15 years, only to give it up 5 years ago. She doesn't smoke now. Past medical history, hypertension, hyperlipidemia, and COPD, surgical history, appendicitis in her 30s, family history. Father passed away from myocardial infarction at the age of 84. Mother passed away from breast cancer at the age of 80. Brother is 62-year-old, still living with hyperlipidemia and high blood pressure. Daughter is 39 years old. She's healthy. She doesn't have any medical problem. ROS, as stated above, the only focus area here for the patient is the respiratory system. Patient complained of shortness of breath with coughing up yellow tinged sputum. Cardiovascular, no feeling of chest pain, but experiences some chest tightness. Other than that, no prior CV cardiovascular disease history or any other concern for the ROS. Objective information: vital sign, temperature is 101.9, heart rate is 105, RR is 33, BP is 128/76, SpO2 was 92%, kind of fluctuate between 92 and 93 and deep down to 91%. On room here, height is 5 feet 9 inches, weight is 185 pounds, BMI index was 28.9. Physical exam, the focus area is cardiovascular system. Patient is tachycardic with heart rate at 105 beats per minute with slight chest tightness. However, SIS2 and RR noted, no gallops or murmur auscultated. Other than that, pretty much unremarkable. Lung sound, the base of the lung, left posterior wall auscultated for crackles. In the left chest, there are few light wheezes that may be heard. Over the lowest part of the left lower lobe, there is egophony. Although there are no adventitious noises, the right lung breath sounds are marginally attenuated. No right lung egophony is present. No using of auxiliary muscle. Assessment: differential diagnosis, pneumonia, bronchiectasis, acute exacerbation of chronic bronchitis, pulmonary embolism, congestive heart failure. Assessment continue. Resources used to narrow the differential, according to my Cleveland Clinic, .org 2023. That's pretty much the resources that I use, which is given as high fever up to 105, coughing up green, yellow, or red, mucus, tiredness or weariness, breathing quickly, respiration difficulty, quick heartbeats, chills or respiration, stomach or chest pain, especially when coughing up or taking a big breath, decrease in appetite. So all these combined, when compared with what patient presented with, it kind of match. Then this is the reason why I come up with pneumonia. My critical thinking process: the patient has a history of COPD and was diagnosed with bronchitis last year and was treated with antibiotic. And now the clinical presentation is shortness of breath that began a week ago with productive cough of green, yellow sputum, fever along with it, and fatigue. The patient appeared tachypneic with SpO2 fluctuating between 92% to 93% on room here and sporadically falling to 91%. So patient is tachycardic at 105 heart rates. Even though there are no abnormal heart sound, the diagnosis of pneumonia kind of fits patient presentation. The plan for this patient is imaging of X-ray and CT according to Shatter and Sharma 2022. Blood tests, which is going to WBC, blood culture before any antibiotics is going to be considered. Sputum test, the patient is going to be eventually admitted in the hospital. Pulse oximetry is necessary to kind of measure how much oxygen patient in the blood that patient is getting, and also check how the lungs are functioning well. Arterial blood gas could be done at the in the hospital, and also EKG is necessary because of the tightness of chest. So with all this, I consider sending the patient to the hospital because at the clinic there is no EKG to be done. We don't have the equipment for that. And also the blood, we have blood, but we cannot have immediate results. So that's the reason why I consider, since all the tests, there are numerous tests to be done, and giving patient a condition in relation to the assessment that was carried out, I think the best fit for the patient is to be sent to the ER, which I did. I sent the patient to the ER expecting that lab results, when it comes back, if there's any, the blood culture is done, which is going to take a few days to result. And if the x-ray reveal consolidation, the lungs, then definitely patient might be considered to be admitted in the hospital for pneumonia. So if it's bacteria, then the right antibiotic will be started. Also, regarding the plan and treatment continue, according to Nafaji and Sandrock, 2017, they consider in two different scenarios. If patient is going to be an outpatient or is going to be hospitalized in the hospital, different type of treatment, antibiotic treatment that can be undertaken. Macrolides antibiotics such as azithromycin and clarithromycin for 3 to 7 days for patient that is risk-free of any other complication of pneumonia, which could be treated outpatiently. And also for hospitalized patient without the risk of developing multi-drug resistance should receive intravenous antibiotics for 7 to 10 days. So this is pretty much the list of kind of antibiotic, levofloxacin, cefotaximide, ceftriaxone, ampicillin, and all that for this patient. Also, education / non-pharmacological intervention for this patient. Patient is advised to avoid smoking. I know she has stopped smoking right now, but these are the things that are considered for the patient. Exercise, maintain a nutritious diet, and get enough sleep. And refrain from using alcohol. Home remedies for this patient for pneumonia, according to WebMD.com 2022. Water. Patients should stay hydrated by drinking water, tea, or soup. Drinking plenty of water will allow patients to stay hydrated, and that will kind of liquefy the mucus. So whenever it coughs, it can bring it up easily. Apply warm compress to kind of help lower the fever. Soothing steam, lung mucus loosen due to moisture in the air. So breathe steam from showers or bath, or install humidifier. Try turmeric. According to WebMD.com 2022, South Asian turmeric has a history of treating weariness, pain, and respiratory issue. Genuine rest. Patients should consider staying in bed until noon or couch potato kind of rest. Also, exercise the lungs, strengthen breathing exercises such as coughing, deep breathing, and blowing through in order to recover from pneumonia. Avoid being overly eager. Patient is advised to resume regular schedule after full recovery. To avoid school or any work until patient is fully recovered. Holistic approach and caring science. According to Waxing, caring must come before anything, even medical intervention. The philosophy contends that people cannot be treated as objects, isolated from oneself, others, or nature, even while it acknowledges the advantages of medicine. The emphasis should be on the interpersonal relationship between the care provider, the nurse, or nurse practitioner, or the care recipient, the patient, which with humans being seen as treated as a component of larger shared society. And for this, I use the nurture, the kind of foster relationship between me and the patient. Like for instance, the patient didn't want to go to the hospital, but I kind of encourage her by talking to her and building the trust in the kind of judgment that I made, that I have her best interest at hand. That going to emergency will provide higher level of care which the patient would need. Otherwise, if I send the patient home, patient may not do well, and at the end of the day, she may be sent back to ER. So by looking at the patient as human being, instead of looking at the patient as a pneumonia, because of the pneumonia that she has, is treating the patient as a human being. I look at the human being first, that I'm dealing with a human being like myself, instead of degrading the patient because she has pneumonia. So also I kind of balance things out by addressing the need of the patient in readiness to kind of accept the education that I gave to her in terms of teaching her, in order for her to understand the importance of the level of medical problem she has, the pneumonia. So which kind of help to understand, and she eventually agreed to go to the ER, which I sent her to. Overall, the overall thing is by combining the various forms of interventional treatment plan that kind of incorporate pharmacological, non-pharmacological, and home remedy for this patient, it kind of make it to be holistic. And finally, these are the references, and thank you so much for listening.